Recently, during the World Economic Forum in Davos, Switzerland in January 2026, the President of the United States, Donald Trump, was noted to have extensive bruising on one of his hands. Understandably, this gained significant attention and concern for his medical well-being, given that he's not only the President of the United States, but the oldest active sitting president at age 79. Donald Trump and the White House subsequently came out and stated that the bruising on his hand was likely as a result of him taking a daily high-dose aspirin. This comment generated significant attention in the medical community because typically low-dose rather than high-dose aspirin is recommended. This resulted in headlines such as the BBC stating that Trump says he takes higher daily dose of aspirin than doctors recommend. In this video, we're going to explore how aspirin, as a member of the NSAID, non-steroidal anti-inflammatory class, works, how its mechanism is slightly different than other NSAIDs, why people or patients take this on a daily basis, and is there any benefit or drawback to taking high-dose versus low-dose aspirin on a daily basis. Looking at the mechanism of these non-steroidal anti-inflammatory drugs, they work pharmacodynamically by breaking down arachidonic acid through two primary pathways propagated by these COX, cyclooxygenase enzymes, of which there are two. COX-1 is active constitutively, meaning all the time, and this COX-1 enzyme turns arachidonic acid into GI mucosal prostaglandins, which protect the GI mucosa from ulcers and bleeding, as well as platelet thromboxane, which promotes platelet aggregation and hemostasis. This stops you from bleeding. This is opposed to the COX-2 enzyme, which is inducible, meaning turned on as needed, and this COX-2 enzyme results in prostaglandins that mediate pain, inflammation, and fever. So when would a patient take an NSAID and how does it work? Most typically, patients take NSAIDs because they want to stop pain, inflammation, and fever. So they take an NSAID that works on this COX-2 enzyme, thereby shutting off those byproducts. For example, if a patient has an infection like influenza, the flu, or a common cold, they'll take ibuprofen, Aleve, Excedrin to stop the fever. Or if patient has arthritis, like rheumatoid arthritis, or they just had an orthopedic surgery, they'll take an NSAID to stop the joint pain propagated by these prostaglandins, to stop the inflammation and pain. But when patients take these COX-2 inhibitors, they often also affect the COX-1. And this is why, as a GI doctor in Las Vegas, the most common cause of gastric ulcers and upper gastrointestinal bleeding that I see are these patients that come in who have been taking these ibuprofen, Aleve, Excedrin, usually for their joint pain on a daily basis for a couple weeks. That's because when you inhibit this COX-1 enzyme, you have none of these GI mucosal prostaglandins to protect the GI tract, causing GI ulcers and bleeding. Now, let's get to how aspirin works, and that is through this final pathway. When you inhibit the COX-1 enzyme, you inhibit the thromboxane, you inhibit platelet aggregation, and you inhibit hemostasis. This is beneficial because it gives a cardiovascular protective effect. For example, when you have a myocardial infarction or a heart attack, that's from a blood clot in your coronary arteries. Inhibiting the platelet thromboxane helps protect against that. When you have a stroke, a clot goes to the brain and decreases blood supply, causing an ischemic stroke in the brain. Inhibiting platelet thromboxane protects against that. Aspirin is unique in that not only does it inhibit COX-1, but it does so in an irreversible fashion, resulting in complete shutdown of this thromboxane for 7 to 10 days. And this is why many of my patients you yourself or many of your loved ones take a daily aspirin, whether low or high dose, which we'll discuss, to help prevent clots, strokes, heart attacks, and thereby giving a cardiovascular protective effect. Different NSAIDs have different specificities for each of these COX enzymes, and interestingly, many of the COX-2 specific NSAIDs were taken off the market, such as Vioxx, and this is because they increased your risk, paradoxically, of heart attack or stroke. This is because if you specifically inhibit the COX-2 enzyme, more of this arachidonic acid will go down the COX-1 pathway, resulting in increased thromboxane, increased cardiovascular risk, heart attack, stroke. That's why Vioxx was taken off the market. If we look at a comparative analysis of COX-1, COX-2 ratio selectivity, you can see Vioxx, which was rofecoxib, has a greater than 50-fold COX-2 selectivity and was taken off the market. Aspirin, as you can see, is not very specific, and that's why it works through the COX-1 enzyme and giving that cardioprotective effect. Now that we've discussed the mechanism of aspirin, NSAIDs, and how they work, let's talk about the controversy behind Trump saying that he takes a high dose versus low dose aspirin every day. Is there any benefit to taking a high dose versus low dose aspirin? And is there any risk taking high dose versus low dose? Perhaps the largest study comparing high or low dose aspirin was this adaptable study, appropriately named Comparative Effectiveness of Aspirin Dosing in Cardiovascular Disease. The goal of this study was that the appropriate dose of aspirin to lower the risk of death, myocardial infarction, and stroke, and to minimize major bleeding in patients with established atherosclerotic cardiovascular disease is a subject of controversy. They looked at over 15,000 patients that were followed for 26 months. The outcome in terms of cardiovascular events was death, hospitalization for myocardial infarction, a heart attack, or hospitalization for stroke. They also looked at the adverse events, meaning hospitalization for major bleeding. They found no significant difference in cardiovascular events or major bleeding events between patients assigned to take low dose, 81 milligrams, versus high dose, 325 milligrams daily. You can see that represented in graphical form here, showing cumulative incidence of cardiovascular events over time with no difference between the high and low dose aspirin group. But also, at the same time, there was no significant cumulative incidence of major bleeding between the two groups either. They defined major bleeding as any kind of bleeding event that necessitated a blood transfusion. So, in summary, although Trump did generate controversy like usual in stating that he takes a high-dose aspirin, this does not appear to be wrong and that it is not inherently riskier. But at the same time, it doesn't provide any additional cardiovascular protective events, so there's very little difference, according to the data, of taking a high-dose versus low-dose aspirin. Now, I will say that in this study, major bleeding events implied that the patient had to be transfused a unit of blood in the hospital. Clearly, some bruising on the hand does not necessitate a hospitalization for transfusing, but I could not find any studies comparing the incidence of bruising with high-dose or low-dose aspirin. But in summary, I hope you enjoyed this video. We spoke about how aspirin works as a member of the non-steroidal anti-inflammatory class. We compared the biggest study looking at the differences in risk of high and low dose aspirin, of which there were none. So I appreciate you taking the time to watch this video. If you have any questions, go ahead and ask in the comments below. Otherwise, I will see you in the next one.